Day-to-day observation practice, probably it is one of the most important X-ray we have to analyze. First thing, what are the X-ray we suggest and how it is being done? Sometimes radiographer are unable to give you a proper X-ray. Then how you can make the thing correct? Now most of the important X-ray we do go for in the pelvis, AP view, pelvis, include both hips. So it is better, it is said, if you take the AP view, if you keep this limb rotated internally 15 degree, probably it will give you more information rather than in external rotation. So AP view. Now how to take the AP view? AP view, you know, anterior spine line, and this is a simple view. So is the beam should come directly like this, and film is like this. So you have a film like this in the ground floor. So like this is AP view, and keep the limb. Yes. Now if the X-ray is okay, then you analyze the X-ray. Is it correct, right or wrong? We'll discuss one point. This is AP view. What about the lateral view? There are three lateral views mostly. One is frog lateral view, which is being shown over here. For lateral view advantage, you can have this both the lateral view of the bed in same view. How exactly do we? It is like the frog. No, it is like this.
45 degree.
See, you are addressing these two heavy, flex and abducted. So this is going to give a pedal flexor and comparison between the two. This is your frog lateral view. ঠিক আছে কথাটো? This is called frog lateral view. This is like the shape of your frog. You are flexing like this, abducting it. Take a AP view, you will get the lateral view of the both hips. One. Number two is that what is cross table lateral view? Cross table lateral view is the same that you see arm. So you are keeping like this. You flex the other side down, and beam is coming from this side, and beam is lying parallel to the neck. So beam will be like this, parallel to the neck, and the beam is coming from this side. Yes, it is said it is better if you keep the limb a bit internal rotation. So if it is internal rotation, that means you are correcting the anteversion. So it will give better X-ray. This is for lateral view. Cross table lateral view. So if the technician unable to do so also, you for betterment, you flex it. It is just like the same you do in the CM. So if you do it, give it an internal rotation, it will correct the what? Anteversion, and the beam is coming like this, and you give a better function. ठीक है sir? Then analyze western view. Western view, you turn the limb like this. 45 degree. Western view is there.
Western.
Then western view. Then if you are this is like your ilial view sort of thing. Almost just like your ilial view in pelvis, same thing, almost same. So this view also going to give you lateral view. So lateral view 3. One is frog lateral view where you can see both the neck and hip. Yes, compare it. You can see this is your frog lateral view. So you are seeing both the lateral view in the same film. But for betterment, one can go for the cross table lateral view. Cross table lateral view, flex, opposite beam, like this, you are getting it. Another is to instant view. Most important is cross table lateral view is good. Okay, now AP and lateral view is over. No? Then inlet and other views are not for this. This is for your hip. Now, how to analyze this X-ray? This is more important. These are the X-ray most of the time we need, AP and lateral view most of the time. Then you for betterment one can go for CT scan, MRI, etc. But since X-ray is one of the basic requirement of your pelvis. Basic informative. Sometimes it is more informative than that of CT scan and MRI, because you can have a broader picture. You have a comparative also. So even if you have a cross-sectional view, okay, that is giving more details. Even then for overview, it is the X-ray which is going to give you a good perception. Now, how to analyze the X-ray? These are important things. One, I have already mentioned that while you are looking for the X-ray, you are looking for the symmetrical. Whether it is symmetrical or not symmetrical. Symmetrical, you will know about the level of the eagle. Yes, and your abdomen. And most important thing, whether it is a pure epiphy or not, you will know from the tip of the coccyx, which will be corresponding to that of your sympathetic. Now again two things may happen. Normally this gap is almost 1 to 3 centimeters. Now while you are taking the X-ray, you will find this beam is coming around 1.5 mm. Meter. 1.5 meter. So if it is deflection, pelvis deflection or extension, that will be telling that the gap is more deflection. It is less, it is extension. So from this beam also you can know. So normally this will be almost 1 to 3 centimeters. This should tell you whether this line is straight or not. Then other lines we are not going to discuss, but for the betterment. So this is what?
Iliopubic.
This is what?
Iliosteal line.
And two things are there. Two things are there. We'll talk about this. So, how do you delineate the anterior border of the acetabulum and the posterior border of the acetabulum? There are two lines, see? There are two lines, see? One is this, another is this. Which one is anterior, which one is lateral?
So anterior is a bit acute, sir. So
Anterior one is more medial.
So a bit acute, and the posterior border is like this.
So, again there is a relationship. We'll talk about this. Inclination, whether it is inclining towards the anteversion or retroversion of the acetabulum, one can know from the line also whether they are making a or there is parallel. But anyway, so these are the important things. So to know that whether my X-ray is correct or not. And for lateral view again same thing, symmetrical thing. Now analyze this X-ray. 1, 2, 3, 4, 5, 6. One thing is, number 2, where is your teardrop? What are the analysis? One is the length. How do you know the length? Teardrop. Teardrop means your line is actually to be cut. Here you have the lesser trochanter here. So draw the line in the lesser trochanter here. This is the suppose this is the lesser trochanter. And this is your teardrop. Yes or no? This drop is teardrop. So you draw the another line from here. This is what? This is what? This says about the length of the limb. Length. Limb length. So if it is going up, supposing hip is migrating up, so necessarily the gap will be less. So these symmetrical means that they are in the same level. Are you getting my point?
Yes.
So if there is a conversion, supposing there is a dislocation of flexor neck of the femur here and this is going up, necessarily lesser trochanter will go up, but teardrop will remain same. So there will be conversion. In indicates there is a beam length is here. There is inequality in here. So this is beam length. Okay, sir? 1. What are the points are? Number 2, neck shape angle. Neck shape angle. So how to draw it? Center. There. Center draw. One is your, this is very short one. Actually, we suppose it is a longer one. Do you have another point?
Yes, sir.
Neck shape angle. How do you it's a neck shape angle here. Okay, fine. In a neck shape angle, see. How do you know it? What center of the
External rotation, sir.
then neck and one long axis from the
External.
femur. Suppose the
External
point
rotation,
and
LT is very prominent.
another this will be very I am heavy. So you draw the line. One line is coming like this, another line is going like this. Yes or no? Yes or no? What is this then?
Next step.
Next step. Oh, drop. What is the normal length?
125.
40, up to 140 one can say. So if it is less, then what do you say it is?
So if it is less coxa value.
Coxa, and it is more coxa. So this is important. So to nomenclature to whether deformity is there or not. So if it is beyond the limit, then you have to say it is coxa or coxa. Then one more thing in the neck is also look for the trabeculae. Same. We have discussed about the trabeculae also. So this is one can see there is worst triangle.
What's triangle?
What is worst triangle?
Trabecular.
There is no
No,
trabeculae. No trabeculae there.
No trabeculae, there is a zone between the two ribs. So
Secondary compressive.
these are coming, these are the primary. Primary compressive.
Compressive.
And other side going a primary, secondary and primary tensile trabeculae. So one is tensile side.
Tensile and compressive.
Ah,
Primary
yes,
compressive,
that is
secondary
right. That is
compressive,
it
and
is
tensile.
so one and this is the primary compressive trabeculae. Then again if it is going, it is a secondary trabeculae. Then tensile trabeculae will be coming from this side.
Yes.
So you have a triangle here. It's called what triangle? What triangle? Huh? Then what is this white zone? This is your calcar. So less calcar or less trabeculae prominence indicates what?
Osteopenia.
Osteoporosis. So one person, you know, Dr. Singh's index. Singh index was actually a radiological quantification of osteoporosis before invention of DEXA or CT or MRI. So this is a radiological basis of quantification of osteoporosis, particularly studying the hip. So this is radiological quantification by Singh's index. There is gradings. So indicates that the disappearance of this your trabeculae indicates osteoporosis. What triangle? Okay, sir? This is okay. Then if you go back, what triangle? Then what are the things you study? One is always study about the joint space. There are 3, 4, 5 points. A is alignment. As I said, alignment is applicable here also. So alignment indicates a symmetrical or not symmetrical. What is it? A. B for the bones. C for the cartilage and artery. The C, the bone of the bone. Now you have to study the bone. So if there is any abnormality, you have to describe. C is mostly you cartilage. So this is called joint space. What is the importance of studying the joint space? Whether the joint space is uniform throughout the course or not. One is concentric, one is universal. Concentric means if the reduction of the joint space is taking one place, one, other part is white. And another is the uniformly this is reducing. What are the basic meanings of it? If the infective pathology is there, if the destruction is limited to one side, so it will be a reduction of the joint space uniformly, or there is a consecutive one part reduction will be there. That is important. Two things are there. So one, in joint space you have to study whether there is a uniformity of the joint space side or not. One. Suppose the joint space is this here and this is uniform. It is reduced, you have to say. It is reduced. Right side is reduced, left side is uniform. Uniform means what is? Our joint space should be also uniform. Uniform throughout the area. Both. In a case of your posterior dislocation reduction X-ray is also important. Whether it is a concentric reduction or a non-concentric reduction. That means joint space which is reduced, but one side joint space is more, another side. It indicates there is something obstructing there. The important thing, particularly evaluating the post-traumatic reduction. That's it. in pathological condition, what are the importance? Pathological condition, one condition is that joint space is reduced throughout the fibula. Where you get it? Arthritis. Seronegative spondyloarthropathy and arthropathy. But septic arthritis, inflamed arthritis, you will find reduction is only one reason. That is also analyzing of the joint space. So joint space analysis is also important, whether it is uniform both sides. Is it uniform throughout the course, throughout the area? If it is reduced throughout the area or reducing one area. One area reduction is mostly you will find in case of infective septic arthritis or arthritis. But uniform reduction mostly find in seronegative spondyloarthropathy or inflammatory condition. Yes, sir? Joint space. So one is your joint space. Now, again we will go for the further thing. Yes, sir? We have symmetrical joint space reduction, angle, lines. Then another point is what is CE angle?
Center edge angles.
No. Center is angle. What is the importance of this angle? That's right. Come here and show. Find out the center. Number two, in the joint space situation, then again one can comment on the spherical shape of the head. One question I have. Only things you have to tell, and decide also you say about the symmetrical, whether it's spherical or not spherical. Head is spherical, not spherical. Spherical, not spherical. Not spherical means some sort of irregularity is there. So you will find in case of avian or other pathological condition that infective condition somewhere that the head is not spherical. The spherical can be commented from the actually point sort of thing, whether round, it is round, or you can place it there and see whether uniformly it is there or not. Or on the other hand, even you can have a comparative study between this round and the side. So it should be spherical one. Non-spherical means some sort of pathology. So in the B part of the analysis of the bone, then again you are saying that my head is not spherical. Not spherical means some sort of pathology, maybe traumatic, maybe infective, whatever it might be, non-spherical. So spherical, non-spherical head. Joint space, uniform, non-uniform, not uniform, whether concentric or reduction is the one particular area. Infective pathology or inflammatory pathology. Now next one is that some other things where are important, like the find out the center of the head. So you arbitrarily get a point sort of this and this is your. Now how do you draw the C angle? Draw. Get a concept? Draw the C angle. Draw the C angle. C angle is important. What is the normal lens? Almost 20. The two things in here. This angle indicates what? What is the importance? When being drawn. Number two, also coverage of the head. Coverage of the head. Sometimes the head is over-covered. Sometimes less covered. Less covered means it is vulnerable for particularly your this place here. One angle is on the edge of this lateral edge of the acetylene. Another line from the horizontal line. This angle is important. So more the angle, more or less. Less angle means what?
Less coverage.
More covered. Sometimes you will find the hair is more covered than this essentially lead to your concentric area. Then lead to reduction of the range of movement. You see my point? One is line, this is line is one line drawing from vertical line, another is this. This area indicates what? One weight bearing. And also the edge of this acetylene. The edge is going towards the more this side in means the overcover. And if it is coming to this side, it is dysplasia. Okay, sir? That is one. Got my point? That is one.
Base angle more.
Less the angle, it is covered below, relative movement is decreased.
The importance is what? Important they discuss about the weight bearing zone, and particularly in a situation of post-traumatic post-trauma. Whether you need to go for operation in this case or no, it will be determined by this area. If there is integrity is there, it means it is in the safer zone. Probably may not need to go for operation. But if the integrity is lost, you may need to go for operation. Got my point? Then another is acceptable inclination. How would you do it? Now, whether acetabulum is covered, as I said, one thing, that one point, this is a C angle to weight bearing. Another line, sir, you look at this, look at the
Sclerosis.
superior part of the acetabulum. This is you have
Sclerosis.
sclerotic part. So one point is there, this is your medial edge of this acetabulum, sclerotic margin. Draw a line like this. Draw question. Another line is draw from through the edge of the acetabulum. More the angle, more the displacement.
Yes.
Less the angle, more the coverage. Normally 6. আচ্ছা এটা লাইন এটু হবো এটা লাইন হবো নয় one line is there, you draw a line from this here বল নয় এটুকু আচ্ছা another line is you are drawing like this from the edge, another line is this but angle, this is the I am explaining it. See, this is the sclerotic part of the acetabulum, this is medial end, lateral edge. One line is drawn to the lateral edge, and another line is drawing from the edge to the lateral edge, to the lateral margin of this. The angle between these two, lesser is covered, more is the displacement. Suppose you had it in the case where the lateral edge of it is lying over here, the angle you are drawing from here will be more. If it is more, means coverage is less. Coverage is less means potential displacement. So these are the angle. Getting my point? No. See, look at this edge. Look at this thing. This is medial edge of the sclerotic. This is what? This is lateral edge. You are drawing a line like this. And again, on this angle, you are drawing another line to the edge of the lateral edge. From this point to the lateral edge. So, if the lateral edge is down, the angle between these two lines will be narrow. If it is lying like this, and the line is going like this, angle is small. More the angle means what?
Less is the coverage.
Less coverage. That is your exactly point. So less coverage means more displacement. ঠিক আছে কথাটো? Sing-sang, are you getting my point? Yes or no? Yes, very good. So these are the points, these are the lines, na? Then again, okay, let us see where the anterior border and the posterior border. Find out the anterior border and posterior border of the acetabulum. Anterior border is always
Medial.
so and lateral border is
Lateral.
so that things may happen sometimes. So it is retroverted, anteverted. If it is anteverted, then line should be what? Distinct. But if it is retroverted, what will you get? It will cross. Superimpose. If it is superimpose, they will make an angle of 80. There are two lines there. The one is almost this line, another is this line. So middle one is what? Anterior. And this one is posterior. Now they are making it. What does it mean to us? So anterior is lying more medially, posterior lying laterally. This normally happens. That means it is facing anterior. So if it is retroverted, going like this, what will happen? It will cross. Line will cross each other. So line will cross and make an angle of almost 8. Figure. What does it mean to us? This is retroverted. Did you have one? No. So normally, see there are two lines. Right now we are very distinction. So one is vertical, another is this. This one, this line is almost coming posterior line, this is anterior line. So anterior line is supposed to be medially, posterior is laterally. It is normally seen. But in a case of retroverted one, there will be overlap. So they will make an angle of almost separate 8 separate. So it indicates what? ACWM is retroverted. ACWM retroverted. ठीक है sir? So you know it. So these are the things you have to analyze in the head. Are you getting it? So, you have to analyze all the. There are certain other things are also there. But later you on again you see. Another point I have to tell us. How do you know that it is Prof acetabulum? Prof acetabulum. This what is this line?
So if the dome crosses the ilioischial line,
We have commented about the varus. What is this? Varus. 1.1 mention about the engine accepting. Now, one point is sometimes covered whether it is Prof acetabulum or not. How radiologically say it is a Prof acetabulum? We say that this line, see this is here, the white line, this line is what is this?
ilioischial line.
Very distinct, no? And this line is levitation. So if the head is crossing the ilioischial line, that indicates it is a case of your Prof acetabulum. Prof acetabulum.
Sir, it is the
Chavitra?
sir, it is the head or the dome, sir.
Huh?
Sir, head or dome, sir.
Head or dome? Dome. So this head will be coming crossing like this. Yes or no? So if the head is coming to crossing this line to this side, sometimes you can get, sometimes in your stimulation other thing, head is going medial. And also particularly totally replacement, you will find sometimes post-traumatic cases. The medial wall is open, it is going central flexor dislocation, it is going towards the more medial side. Old case of central flexor dislocation, it is going more medial. And it is crossing this line. That's why it is called protrusion. So whether the head is protrusion acetabulum or no, then you have to reconstruct it. Yes or no? It is important thing. Important thing there. So these are the important things. No? Now you know what is this line, one central line like this. The gap between this line is not what? Offset. One axis is like this, another from this. This is offset. Offset is very important, particularly for lever mechanism of this abductor mechanism. Yes, sir. So in abductor mechanism, the lever is very important. For the saw, efficiency is less. So many things are coming up. In the APU, we have to analyze about the alignment. We know about the symmetrical part. Asymmetry will indicate something else. Flexion of the pelvis, extension of the pelvis, neutral pelvis. How do you know it? You know it. Then you have to analyze all the things. Bony part, particularly you know about the head. This is your sentence line. This sentence line. Then again the head, whether the head is spherical, non-spherical. Then again we talk about the C, the gap between these two, whether it is symmetrical, not symmetrical. Non-symmetrical, whether it is concentric reduction or a eccentric reduction. Eccentric, concentric will indicate something. It also critically we have to analyze. Then again we look for this angle. Normal angle, whether the next angle is maintained or not. Yes? Yes. Then again look at the head and see for the various trabecular lines. Osteoporosis will indicate absence of trabecular lines and the more prominence of this watch triangle. This is here about the osteoporosis, the quality of treatment. Then again you talk about the protrusio-cerebellum. Whether it is crossing over the ilioscale line. Then again we are talking about the acetabulum and the head. Then whether it is covering more or less covering in those various angles. C angle is very important for us, particularly the integrity of the brain joint. Lesser, that more is good. At the edge of the vertebra, acetabulum is also delineated by the angle we have said, acetabulum. So if it is over-covered or less covered. Over-covered will also bad, less covered is also bad. Over-covered will
Impingement.
minimize this range of movement by the angle. Impingement. If it is less, then again it is vulnerable for dysplasia or whatever. Yes, sir? So many things are coming up. So many things are coming up. We have to analyze the X-ray of the pelvis like this. Yes, sir, how to take the X-ray, what should be the position, and how we were analyzing this X-ray. Analyzing the X-ray and what is the importance of this. Yes, sir? Any question?